Welcome to today's Explainer. We are stepping into the fascinating world of cardiovascular physiology to unravel a true medical detective story. We're going to decode the racing heart. Have you ever wondered what exactly is happening when the heart's electrical system just suddenly misfires, sending its rhythm into a chaotic, rapid sprint? Well, it's a scenario that plays out in emergency rooms every single day. So today, we're going to learn exactly how clinicians track down that electrical short circuit and, more importantly, how they stop it right in its tracks.
Okay, let's dive into this. Picture a patient sitting right in front of you. Out of nowhere, their heart rate spikes to 160, or maybe even 180 beats per minute. They're feeling palpitations, shortness of breath, maybe getting dizzy. This is an absolute emergency, right? The heart is beating so incredibly fast that it simply can't fill and pump blood effectively. As a clinician, you're faced with a high-stakes puzzle, diagnosing a narrow complex tachycardia. How do you find the exact location of the short circuit hidden deep within a beating heart? Well, we are going to explore the precise step-by-step logic used to solve this mystery, relying entirely on the heart's hidden signals.
Here is our flight plan for today. First, defining supraventricular arrhythmias. Second, mechanisms of PSVT. Third, clues in the 12-lead ECG. Fourth, the AV nodal blockade. And finally, decoding the arrhythmia.
Section 1. Defining supraventricular arrhythmias.
So supraventricular tachycardias, or SVTs, are essentially abnormal rhythms that originate above the ventricle, specifically up in the atria or the AV junction. The key defining characteristic here is a heart rate over 100 beats per minute coupled with a narrow QRS complex. That means it lasts less than 120 milliseconds. Now, why does that narrow QRS actually matter? Because it tells us that the electrical activation is still traveling completely normally over the Purkinje system, the heart's built-in wiring, down into the ventricles. Basically, the wiring downstairs is fine. The emergency is happening entirely upstairs. This keeps our clinical investigation strictly focused on the upper chambers of the heart.
Section 2. Mechanisms of PSVT.
Let's talk about paroxysmal supraventricular tachycardias. Paroxysmal just means these rhythms have a sudden onset and a sudden termination. They act like a light switch. Our two main culprits are AVNRT and AVRT. First up is AVNRT, or AV nodal reentry tachycardia. This is actually the most common paroxysmal sustained tachycardia we see in healthy young adults, particularly women. In AVNRT, the short circuit is this tight, localized reentry loop sitting right inside and around the AV node itself. Then we have AVRT, or AV reciprocating tachycardia. This one is a much larger electrical loop. It uses an extra abnormal electrical connection called an accessory pathway. This is what you might see in Wolff-Parkinson-White syndrome. The electrical signal travels down the normal pathway to the ventricles, but then it actually sneaks back up to the atria through this secret back door, creating a massive racing loop. To really visualize this, think of the AV node sitting right there in the center of the heart as the ultimate toll booth or a master junction box. For both AVNRT and AVRT, this toll booth is a mandatory part of their chaotic electrical circuit. Those rapid electrical signals absolutely must pass through this bottleneck to keep the racing rhythm alive. And you know what? That anatomical bottleneck is going to become our greatest advantage a little later in our investigation. But wait, we can't forget our third suspect, focal atrial tachycardia. Unlike our first two culprits, this arrhythmia completely ignores the AV node toll booth. It is driven by abnormal automaticity. So think of it as a rogue group of cells going totally off script and firing all on their own, or a tiny microcircuit completely confined within the atrial tissue itself. What this means clinically is that even if you block the AV node, this particular suspect is just going to keep firing away in the upper chambers like nothing happened. Section 3. Clues in the 12-lead ECG.
Now, to decode the arrhythmia, we have to follow a strict clinical algorithm. Step 1. Obtain a full 12-lead ECG with a long rhythm strip while the patient is actually experiencing the racing heart. Step 2. We hunt for baseline clues. Is there ventricular preexcitation that might suggest an accessory pathway? And Step 3. This is where the real detective work kicks in. We analyze the relationship between the R wave, which is that big spike representing ventricular contraction, and the P wave, representing the atrial contraction. We call this the RP interval, and it is absolutely crucial. Let's break that down. The RP interval is our best clue. If we look closely and see a short RP interval, meaning the distance from the R wave to the next P wave is shorter than the P to the next R, it tells us the atria are being activated from the bottom up very, very quickly after the ventricles. This strongly suggests our first two suspects, AVNRT or AVRT. In AV-NRT, it happens so fast, the P wave might literally be completely hidden inside the QRS complex. Conversely, if we see a long RP interval, it suggests the rogue signal is taking longer to get around, which points us straight toward focal atrial tachycardia, or a highly uncommon slow-conducting form of AV reentry.
Section 4. The AV nodal blockade.
So what happens if the initial ECG clues just aren't enough, or if the rhythm is so fast that those P waves are entirely buried? Well, we have to deliberately close the toll booth. We do this using tools for transient AV blockade. We usually start with vagal maneuvers, like asking the patient to bear down as if they're having a bowel movement. That's the Valsalva maneuver. We can also try carotid sinus massage, though we must use extreme caution there and avoid it entirely if there's any suspicion of carotid atherosclerosis, so we don't dislodge a plaque. If those non-invasive maneuvers fail, we bring in the big guns: intravenous adenosine, administered rapidly in 6 or 12 milligram doses. Here's what's amazing about adenosine. It acts as a transient pharmacological reboot. We are literally stopping the AV node's electrical conduction for just a few seconds. By doing this, we pause the ventricles and expose that hidden atrial electrical activity.
Section 5. Decoding the arrhythmia.
Now we watch the heart's reaction to our blockade. If the SVT completely terminates and normal sinus rhythm is magically restored, boom, we have our answer. The circuit absolutely required the AV node to survive. The diagnosis is almost certainly AV-NRT or AVRT. In this case, adenosine wasn't just a diagnostic tool, it was a temporary cure. But if the AV block occurs, meaning the ventricles pause, but you can see the rapid atrial rate is still firing away all on its own, we know the AV node wasn't part of the circuit at all. The likely diagnosis is focal atrial tachycardia or atrial flutter. And if there's no effect at all, or the SVT just slows down slightly and speeds right back up, we either gave an inadequate dose or we're dealing with a standard sinus tachycardia driven by an external factor, like a fever or extreme stress.
However, we always have to respect the sheer complexity of human physiology. There is a really vital clinical nuance here. A very small subset of focal atrial tachycardias are actually highly sensitive to adenosine. That means that even if the rhythm terminates when we push the medication, it doesn't completely, 100% rule out an AT diagnosis. In medicine, as you know, we've always got to keep our minds open to the exceptions to the rule.
Bringing it all together, we have to remember the foundation of our entire investigation. As the source material explicitly states, the ECG is the cornerstone and most important diagnostic test that should be performed on every patient with suspected arrhythmia. Whether we're squinting to find a hidden P wave, meticulously measuring the RP interval, or watching the rhythm respond in real time to an adenosine push, the 12-lead ECG is the canvas on which the heart paints its secrets. It guides literally every single step of our clinical logic.
Think about what we've explored today. By understanding the intricate anatomy of the heart's electrical circuits, reading the subtle timing on an ECG, and strategically manipulating the body's hardware with vagal maneuvers or adenosine, we can take a chaotic, terrifying heart rate of 180 beats per minute and instantly achieve both a diagnosis and a cure. It's just an incredible testament to the power of cardiovascular physiology. And it really leaves you wondering, what other amazing clinical mysteries can we solve just by listening closely to the body's hidden signals? Thank you so much for joining me on this explainer today. Keep learning, keep questioning, and I'll catch you on the next one.